I was told that when you talk to the Dutch and you say, good afternoon, they don't say anything. Good afternoon, ladies and gentlemen. Fine. Today we are presenting the preliminary results of a program to reduce unnecessary caesarean sections by increasing the use of vacuum extraction. As you can see, the first name on the list is Dr. Barbara Norens, my colleague from Kampala. She's actually the PI in this. And then you can see John Lule and what we have called the vacuum extraction interest group, Mulago Hospital, Kampala. Well, when you talk about the vacuum, you realize that we've been mentioning new and underutilized technologies to reduce maternal mortality. I think mainly in our countries, the lower resource settings. And this has been mentioned in a call on action from a Bellagio workshop. I think Bellagio, that's somewhere in Italy. Yes. So among those technologies, vacuum extractions have been mentioned as one of the technologies to improve or to reduce maternal mortality, and to say that vacuum delivery equipment should be made available, and training must be made available and accessible, especially to midwives. That is what was said in Bellagio, but I would say especially to the medical officers in some of our circumstances. And the manufacturer should provide equipment that is more durable, because that is one of the problems, lack of equipment. Sorry, it isn't moving. Next. Again, in a certain other study, when we were talking about interventions, important interventions to be carried out in order to reduce maternal mortality, the training in management of obstructed labor and assisted delivery techniques has been taken as a high priority. Sorry. So, again, when you look at signal emergency obstetric and newborn care functions, we have what we call the health center, the basic health center. The basic health center should be able to carry out those 7 functions: giving antibiotics, anticonvulsants, uterotonics, manual removal of the placenta, and there should be assisted vaginal delivery. This is not a hospital as such, so it is not able to carry out caesarean section, except at the level of health center 4, which is one of the top ones. Now, in other facilities, from health center 4, from the hospitals, district hospitals, referral hospitals, they should be able to do those functions as well as carry out caesarean sections and blood transfusion. Now, what about vacuum extraction? We are talking about vacuum extraction because it does have benefits. One of the benefits of vacuum extraction is the reduced need for surgical interventions. It tends to have less complications, BPH, infection, anesthesia, faster maternal recovery, a net saving of resources. So the second thing is, if I can go back, sorry, back please. Yeah, there we are. The second one, the second bullet is showing that vacuums may help to improve, to shorten the decision to delivery interval, and therefore have timely decision. Particularly, and I could see my colleague talk about the deep head. I've been reading some articles, even from the Americans and from the developed countries, about those caesareans which are performed when the head is at the perineum and is just failing to crown. Those are very difficult caesareans, and they do cause a lot of problems. So, shorter decision to delivery interval has improved neonatal and maternal outcome. The third one is no uterine scar. You have seen a picture of the ladies who have to move a number of kilometers to go to find a hospital, and sometimes in second stage. So if they already have a scar, they have an increased chance of rupture of the uterus. So if they have no uterine scar, they will have less risk of uterine rupture, less risk of placenta previa, placenta accreta, placenta increta. So keeping all that in mind, what has been suggested by WHO, by other researchers, and the realities on the ground, we said, or at least some of our colleagues said, look, why don't we do what we know how to do, which has not been done? For a long time, the vacuum extractions in Uganda, and particularly in Mulago Hospital where I work, have gone down considerably. I myself had left the hospital for other greener pastures. But when I went back, I found when I was a resident, we were having about 25 deliveries, and we could have 5 vacuum extractions. When I went back, we are having 60 to 8 deliveries a night, a day. And there could be sometimes no vacuum extraction. So I said, what is the problem? And my colleague, I'll tell you something more about my colleague. Let me move along. So we said, why don't we implement what we already know? Why don't we implement the use of the vacuum extraction, which has been proved to be useful elsewhere? Now, where did we aim to start? Of course, Mulago, where we work. In Mulago, I think we have the highest number of deliveries in any hospital in the world. I challenge somebody here, anybody here, to show me a hospital in the world where they have 33,345 deliveries in a year. I managed to carry some euros here. I'll pay 50 euros to anybody who will show me a bigger number. So, of those 33,000 deliveries, most of those are complicated referrals, and the vacuum extraction rate was about 0.5 only. I think it may even have been less than that, but because we started looking at it, possibly there was that Hawthorne effect. Now, every year, Mulago produces 10 to 20 obstetrician gynecologists, but it also produces interns, it produces midwives, and most of these are sent up country. So it's a center of excellence in training, which sends people to do obstetric services up country. So it's a very good area to start. It was a very good area to start. You can see where Mulago is, almost in the center of Uganda. And before we carried out this implementation of what we wanted to do, we wanted to find out what were the limiting factors. Why were people not using vacuum extractions, okay? And these are the reasons given. There was lack of skilled staff, there were no vacuum extractors, or there were vacuum extractors which were no longer operational. There were no training opportunities, people were not trained. There was concern about HIV transmission. There was concern about trauma to the baby. Some people were saying they should be done by specialists only, and they are limited in number. Some people thought scissors were safer for the mother. And if scissor was possible, why do the vacuum? And then other reasons. Let me try to accelerate. I have to get another minute because of this gadget. So these are, for those who are saying that there's trauma to the baby, you can see that it may not be strictly true. We'll come back to that later if we get time. HIV transmission to the baby, well, there has been found that with elective scissor, transmission is 8.2. Non-elective scissor, 16.8. That's scissor in labor. Spontaneous vaginal delivery, 16.4. Instrumental delivery was thought to be 18.3. But now, what about caesarean section in second stage? There's no study that talks about that. However, one must remember something, that if you delay to deliver a baby in the case of HIV, the longer you delay, the more the chances of getting mother-to-child transmission. Okay, so we asked questions, opinions of staff. If you had prolonged second stage yourself, how would you prefer to be delivered, or your wife? Now, the specialists, the majority of them were saying vacuum, majority. Midwives, vacuum. Senior officers, residents, vacuum. Okay? And the student, as you can see, the students who didn't know much more about that, they were the ones who are saying, well, I think I would prefer to be delivered by a scissor. So that says something. that possibly those who know more about the subject would prefer to use the vacuum if vacuums were available. Now, after finding out the opinions and the problems and the gaps, we said, what shall we do? The first thing to do was to provide equipment. And with the help of our colleague, we got some contributions. We got some of these Kiwi small vacuums. And then we started work. We did some skills training, and then we put up clinical guidelines. You can see a picture of the senior house officers, interns, getting some training on the vacuum. Down here you can see that that's a model. So we started with the model and then continued under supervision. Now, we collected data on rates of vacuum extraction, fresh stillbirth, that's FSB, macerated stillbirth, early neonatal death, and then maternal death before and after implementation. And we followed then maternal and perinatal outcomes in a cohort of those people who had vacuum extraction during 6 months. The number was about 342. What did we find? The number of vacuum extractions increased because the vacuum extractors were available and people were more confident in carrying them out. So we found that in 1 year we had more than 1,000 vacuums done. Okay? Now, this is a very important slide. Let me combine it with the next one. You can see, if you look at vacuums, the vacuums are increasing. I hope I don't wipe it off. You can see the vacuums are increasing in number. As they increase, then fresh stillbirth rate is coming down. Macerated stillbirth rate is not really, you don't deliver macerated stillbirths with vacuum, so their rate of MSB is not changing. This is the start of the project, and you can see the change starts just slightly before the start of the project, but during the project it goes up, okay? So, perinatal death rate, baseline and follow-up, fresh SBs, fresh stillbirths were at baseline they were high, and then they went down. Now, where did the new specialists go, the specialists that we produced? We had them in Mulago, and then they started spreading all over the country. So you can see where they are at the moment. We hope we may cover the whole country soon. In conclusion, we say implementation was successful, and I'm saying these are preliminary, so you don't really have concrete figures, just some figures. You don't have fancy p-values. We have removed them. After implementation in Mulago Hospital, the perinatal outcomes have improved, and there has been shown to be improvement. And we have also concluded that Mulago Hospital can play an important role in implementing vacuum extraction throughout the country. And vacuum extraction is one of the known interventions that can improve maternal and neonatal outcomes. I would like to add, because the chairperson said something about symphysiotomy, that in some of those patients where a vacuum extraction has been done, especially when the head is fully engaged, when the head is completely in the pelvis, but cannot extend under the subpubic arch, a symphysiotomy has been proved to be useful. Symphysiotomies are a stopgap measure. They are an emergency measure. You cannot say, I'm going to do a symphysiotomy on this one. But in our circumstances, one should be ready to do it, because that may be the only thing that may be able to save the mother and the baby at that particular time. And I'm very happy, and I'll be very happy if you come to Mulago. I'll be very happy to show you how to do symphysiotomy when the case arises. Thank you very much for listening.
Thank you, Professor Lule. We have time for 2 questions, and not too long. Any questions? Well, then it was very clear. Oh, there's one question here.
Thank thanks a lot for the presentation. I think I'll be one of the very new people you'll be teaching symphysiotomy. I have just one question. Yes. The 1,000 vacuums that were done,
Yes.
were those indications the same indications that would have led to a caesarean section?
Now, I would say yes. I would say yes. In cases of delay, or let's say prolonged second stage, okay? Those cases where we did vacuums was where somebody else who didn't know how to use a vacuum would have done a caesarean section. And I can guarantee that is difficult when the head is down. We talk about all sorts of maneuvers, doing a breech extraction, pushing from below, but as you can see, that is not very safe for the bladder, for the uterus. Whereas if the baby is deep down, it is easier to deliver that baby from down than it is from up. Thank you.